I'm going to follow on from Fu's talk to talk much more about some of the more clinical and public health and primary care and community focused elements of atrial fibrillation. And in particular, I'm going to describe some work that we've been undertaking locally based on the West Mid site for almost the last decade or so, focusing on some community work, and a huge shout out to my primary care colleagues in Hounslow, without whom none of this would be possible, but also thinking about some of the acute changes that we're developing in terms of pathways of care, and touching on some of the data and artificial intelligence elements that Fu's already described in his presentation. Let's start with the global picture of atrial fibrillation. So although we're talking about atrial fibrillation in an Imperial Northwest London way, actually the challenges we face as regards to atrial fibrillation span the globe. So I'm going to start with some global data. So this is registry-based data from something called the Global Health Data Exchange Network, which basically logs conditions and data around conditions from countries around the world. And 2050 is how far this projection goes. And in some ways that might seem a very long time away, but actually it's going to be here before we know it, and will probably be within the lifetimes of most of us. And what we're looking at here on this slide is both incidence, prevalence, disability, and deaths from atrial fibrillation, projected forwards from data that we already know from 1997, 2007, 2017. And what you can see is a massive increase in prevalence of atrial fibrillation, which of itself is important enough, but it's the rate of that increase and the consequences that follow that are the real thing that scares epidemiologists and scares cardiologists across the globe. So we are projecting pretty much a near doubling of all of these elements of data. The deaths might look quite flat, but the only reason they look like that is because of the scale of this graph. So globally, if we go back to 1997, there were about 250,000 deaths each year from atrial fibrillation. And by 2050, that's going to at least double. That burden doesn't fall equally in all ages. So within this data set, we've started to look at how it's broken down by age. And what you can see is a significant increase in the prevalence of atrial fibrillation as people age. And you can see the numbers in terms of by 2017, how this had already pretty much increased by a third between those two decades. And if you look at that data, and if you're someone who's been looking at atrial fibrillation epidemiological data for some time, and this paper was published in 2020, it will remind you of something that was published in 2012, so the decade before that. And it is playing out what we were already predicting back then. So this data is more local to us. It comes from something called the OxFASC study, which is a epidemiological study based in Oxford looking at the Oxford population. And back in 2012, they were looking at predictions of what was going to happen in terms of AF and AF-related strokes. Because Fu mentioned very early on in his presentation that probably the most worrisome complication of atrial fibrillation if you're a patient is the risk of stroke. And we know that if you have a stroke secondary to atrial fibrillation, that's much more likely to leave you significantly disabled than if you didn't have atrial fibrillation. And back then, we'd already seen a trebling of atrial fibrillation-related strokes. And that's despite a lot of increasing medication and novel medications that have really revolutionized blood thinning in the context of atrial fibrillation. And by 2050, again, we're expecting to see trebling of that, but particularly focused on people as they're older. And that, because of the way society is changing with aging, that's going to be a real public health challenge for us to face and to deal with. And because of this, we were already saying that decade before that AF should be a public health priority. And that for health systems on a system level is really important. Now, it's International Women's Day this week, so I couldn't move on from atrial fibrillation without talking about AF in women and how that impacts us across the genders. So Fu didn't show you the scoring system for how we try to predict risk in atrial fibrillation and stroke, but being female gives you an extra point on that scale. And part of the reason it gives you an extra point in that scale is if you're a woman, your AF outcomes are much worse than if you're a man. So if you're a woman, you can see on this graph That's the death rate in women if you have atrial fibrillation, and that's the death rate in men. And if you're a woman with AF versus a woman without AF, you can see the huge discrepancy in your mortality. And that mortality hits really early after you receive your diagnosis. So within the first month, you've got an almost combined 8% mortality, which is huge. It's about the same as being hospitalized for a heart attack in terms of the scale of that mortality. So we know that there's a real gender issue and we need to really focus on women's healthcare. So let me bring this down closer to Northwest London. So Fu's mentioned that we've been borrowing from other disciplines. So this map borrows from the Professor of Human Geography, Dan Dorling at Oxford. And what Professor Dorling has done is essentially redrawn maps of countries to highlight health inequalities and to highlight the size of the population. And this is work that was done by one of our registrars, Beth Davies, with Darren Lovett, who was working at the Northwest London Clark as it was back then. So this is England mapped out according to what was, because this is from a few years ago, so before integrated care boards, when we were still all organised into CCGs. This is England mapped out by CCG. And you can see here that London looks very small. And to be honest, I'd be hard pressed to pick out where Hounslow is on that map of London. You can redraw that map using a Professor Dorling-based model to resize that, looking at the size of the population that lives within that area. And you can see the area of London has suddenly got much bigger because of the nature of the population we serve and how many people live in London. And then you can do the same for a particular health condition to really bring out what the health needs and the health inequalities are. And this map shows in the pinks and the darker pinks, shows where our highest areas of need sit across London for this particular health condition, which is undiagnosed and untreated atrial fibrillation. And when you do that, you can see that London comes out very strongly in terms of the health need that we have around this. So we know we have a problem in atrial fibrillation in Northwest London. And I'm going to take you now to the data from Hounslow from when we first started the work. So because stroke is so important both to individuals and to health systems, we have a lot of focus on stroke rate secondary to atrial fibrillation in all of the quality metrics that we run. So when we first started the work, Hounslow is this pink bar on both of these graphs, looking at how many ischemic strokes we have and how many ischemic strokes we had on the people that we already knew had atrial fibrillation. And what you see is that we're well up in terms of the graph, and that's not the side of the graph that you want to be. So when we started this work, Hounslow as an area in the country had one of the highest stroke rates secondary to atrial fibrillation. And it wasn't just in those people that we knew had atrial fibrillation that we weren't treating as well as perhaps we might. It was also in those people that we'd failed to detect, which links into Fu's screening theme. And back then we had about 2,500 people who we knew had atrial fibrillation in our community, and we were missing a significant proportion of them. So we started a piece of work, and I'd say this was done completely with primary care, and to be honest, primary care colleagues deserve the credit for this work because it's not possible without them. And we put in a number of interventions which included standardized clinical templates, education and support, an ambulatory AF pathway. We used a lot of digital tools. So at that time, people had started to develop ECG recorders that you could fit on the back of smartphones. And we were one of the first centres in the country to use them in a large scale way in this sort of population-based level. And as Fu said, it's these digital tools that have really helped us to broaden our reach and to engage communities in ways that we otherwise wouldn't be able to do. And with using all of these approaches, we were able to increase our detection rates by over 25%, so roughly between 25% and a third. And that we could translate not only into detection, but into doing something about it. So there's no point picking up people if you can't treat them. And because we had all of these newer anticoagulant drugs that are easier for people to take, we were able to institute therapy much more quickly than we'd ever done before. So at our baseline, we were getting about a third of people who we diagnosed with atrial fibrillation onto treatment within 30 days of that diagnosis. But by the end of our project, we'd doubled that. So more than 60% of people who we were diagnosing were getting treated within 30 days. And if you looked at a slightly longer horizon, around 80 to 90% of people were getting treated altogether. And that translated very nicely into reduction in actual stroke rates. So using whole systems health data, looking at stroke admissions across the country and including picking up those that were Hounslow CCG related, we showed about a 17% reduction in stroke rate. But it wasn't all equal. So Fu's already said this is an ECG-based diagnosis, and I say that you can use digital tools to pick them up. And we had a huge uplift in the numbers of ECGs that we were doing as part of this project. So you can see we started as a baseline of about 100, and when we were really active, we were doing about 500 ECGs a week in Hounslow to try and pick atrial fibrillation up. But what actually happened is none of this, talking about causality, the ECG diagnosis, the increase in ECG rates didn't actually increase the AF detection rates at all. And what we thought that that related to was about who was coming forward for care and how we as healthcare professionals were supporting them to access the system. So it wasn't quite as opportunistic as we thought it would. And that's led us to continue to develop this work, to look at artificial intelligence and more data-based ways of screening. So many people may well be aware that North West London has a data repository and a data collection system that's called Whole Systems Integrated Care, that we can use both for health service planning, individual care planning, and research purposes. And we were able to use this data set to develop an artificial intelligence-based model of how you might better predict who might develop atrial fibrillation and to retrospectively look at it to see how it might perform. So we were able to show that if you can combine primary and secondary care data sets, that you can increase your AF diagnosis rates by about 15%. And you could, in theory, get a number needed to screen of about 9. And if you compare that to what globally the data shows, where it looks more like a number needed to screen of about 100, that's a significant improvement if we use that in health resources. And we're about to do a study to look at that, see if that actually plays out in real world. So can you take the retrospective analysis and actually translate that into something that works equally well prospectively? Now, I can't talk about atrial fibrillation and clinical impacts without talking about cost impacts. So if the clinical impact should leave us scared, the cost impacts are equally scary. So this is data that's taken from modelling from NHS healthcare resources. And for my primary care colleagues who see a pie chart that says all of the money is going to secondary care, they'll say, well, nothing ever changes there. But the reason atrial fibrillation, I say, is particularly important is if you look at the total amount of the NHS expenditure that we have on cardiovascular conditions and atrial fibrillation as a single entity, it's a huge amount of money. And if we do nothing around the way that we deliver care, the share of that pie that atrial fibrillation will consume will get bigger and bigger and bigger. So we have to look at how we provide acute atrial fibrillation care, as well as that models and detection in the community to reduce the impacts on individuals. And this is where I give a huge shout out to my colleagues in the North West London Virtual Hospital, because I think some of them are on the call today. So what we've been doing is, both at Shell West and as a sector, is developing a virtual model for atrial fibrillation care. So if we look at our own data for acute atrial fibrillation care, and that's the banner at the top you can see on this slide, our mean inpatient stay, remembering that we already have an ambulatory AF pathway, so we will have essentially managed some of the lower risk patients by another way, but our mean inpatient stay was about 7 days. And despite that, we had 10% of people coming back to hospital because of a problem with their AF within 30 days, and then a 30% readmission rate from that. So what we've developed with colleagues in the North West London Virtual Hospital is a digital-first virtual model of care, where if you are picked up with atrial fibrillation, you can be onboarded using digital and actually simple tools like a pulse oximeter and be supported through your AF management journey and have continuing remote monitoring and have a management plan created for you before you leave that virtual ward environment. And that's looking really promising in terms of outcomes, both in terms of patient feedback, but also in terms of healthcare utilisation, with what we're hoping to show as we actually publish our data is a reduction in the length of stay. Now, I can't talk about digital and talk about all the stuff we've done around data without mentioning something about digital inclusion and digital health equality. So we've been doing, alongside all of this other work, some work with our community to understand some of the barriers and some of the bits that we could do that would make healthcare fairer and available to all. So we've recognized that as we develop this model, there are some key things and themes that we need to be focused on and be sure that we address those very early. And you can see some of those themes on the slide. But access, security concerns, accessibility and skills are key themes that we need to address as we go forward with this kind of digital care revolution. So as Fu says, this is a complete team effort, and I have so many people to thank that I couldn't put names on the slides because I definitely forget some people. But what I would say is it's only been possible because of that huge partnership that's been displayed across the system, and you'll see some organisational representation on my slides. And I'll happily stop there. Thank you, Roger.